I am Dr. Sureshvijan, interventional cardiologist at Leelavati Hospital. I am here to talk to you about two issues. One is obesity and heart disease, and another is in-stent restenosis. Obesity has been recognized as a risk factor for heart disease for a number of years. However, the relationship is never constant. We have seen patients who are obese yet don't have any heart disease, and then we see patients who are grossly underweight and have severe heart disease. Obesity expresses its risk on heart disease by the manifestation of increased blood sugars, diabetes, hypertension, hyperlipidemia. These lead to incidence of high atherosclerosis in these patients. However, underweight as a risk factor for heart disease has been poorly understood. We really don't know why underweight patients die because of heart disease, but we clearly know that the mortality from underweight patients suffering from heart disease is very high. And in our population, particularly where we do see patients below the age of below the weight of 60 coming in through our casualty as very high, and the mortality there is substantially much more than the mortality that we see in obese patients. So clearly, underweight patients need to be looked at as a special group, their risk factors identified, and appropriate treatment strategies started as required. I'm here to talk to you about the role of stenting in the management of ischemic heart disease. Ischemic heart disease is due to accumulation of cholesterol in the arteries, and this gradually leads to blockage, which at some stage becomes significant and causes symptoms of angina, sometimes heart attacks. Stenting has been a relatively new treatment for coronary artery disease, where we actually go through the artery in the leg and place a metallic spring inside the artery. This leads to the artery remaining open. Over the years, a lot of developments have occurred in this particular specialty. We started off by using bare metal stents, which were mounted on a balloon, and this was then inflated inside the artery, and the stent was permanently implanted inside. However, over a period of time, there's some reaction between the tissue and the metal in the stent, leading to a recurrence of the block, which we call restenosis. To prevent this, new technology has been inserted. The main thing that we've done is we've put in drugs on the top of stents. These drugs work to prevent the response of the arteries towards the stent, and therefore help in reducing restenosis. There have been a number of trials well established in literature which have shown that this is a very effective and cost-effective therapy in reducing the risk of restenosis or repeat heart attacks. Over the years, a number of stents have now been available. All of them are working extremely well in reducing the risk of restenosis. This is particularly more so in diabetic patients, where the risk of restenosis is very, very high. There has been, of course, a big debate between stenting and bypass surgery. Clearly, stenting being a very non-invasive way of treating heart disease is much more popular. Patients like it because nobody cuts them up. However, it's not something that stenting is for all. There are clearly defined groups of patients where stenting would be more appropriate, and in some groups where bypass surgery would be more appropriate. Stenting would be more appropriate in patients with single or two vessel disease, where the blocks are discrete, located to the major epicardial arteries, and which can easily be covered with a stent. Bypass surgery, on the other hand, would be much more appropriate for people with multiple vessel disease, multiple blocks in multiple arteries, including at times left main stem stenosis, where surgery would be treatment of choice. Over the years, we've seen that despite using stents, in some cases, less than 3% of cases, blocks will develop inside drug-eluting stents. The issue really is, how do we treat these? Till recently, we used to treat them by putting another stent inside, another drug-eluting stent, either containing the same drug or another drug. However, over the last year, a new option has been available, which is called a drug-eluting balloon. This is a balloon which is coated with a drug. You go inside the artery and inside the stent, which is blocked, and inflate this balloon inside the stent where the blockage occurs, and this releases the drug, which gets attached to the inner wall of the artery. Part of the drug, of course, gets washed off, but enough remains in the artery to prevent restenosis. This is a much better option than putting another stent inside the artery. Clearly, because once you have got one stent in, there is a piece of metal inside. By putting another stent, you are increasing the amount of metal inside the artery, the long-term consequences of which are unclear. However, using a balloon delivers a drug which is there already on the stent and which has been used on other stents, and you can deliver this drug safely to that particular portion of the artery, thereby preventing, and I hope abolish, restenosis. So this is really a very good, safe, easy option rather than putting multiple stents in the same artery. However, in some cases, we may find that the block which recurs inside the stent is more diffuse and therefore requires multiple applications. In such cases, perhaps putting multiple stents in might be an option, so long as it's all restricted to one or two vessel disease. If the blocks are there in all three vessels, I think the treatment of choice would be bypass surgery.